Very good evening, everybody, and welcome to our MDT of Management of Chest Wall Tumors by the Southeast Asian Thoracic Society. I'd first like to introduce our team of panelists. The first person is Dr. Padun Ket. He's a cardiothoracic surgeon and a good friend of mine from Bangkok Hospital, Thailand, and he does a lot of chest wall resections over there. So welcome, Dr. Padun Ket.
Hi, how are you?
Good, good.
Hi, everyone.
And the next person I'd like to introduce is Dr. Angela Pang. Dr. Angela Pang is a consultant oncologist in the National University Cancer Institute, Singapore, and in my hospital, NUH. Dr. Angela.
Hi, everyone.
Welcome to this webinar. And the last person of our panelists is Dr. Vigneshwaran. And Dr. Vigneshwaran is a plastic surgeon in Ng Teng Fong General Hospital. He's also a visiting consultant in NUH Hospital, Singapore. And he helps us a lot with our chest wall reconstruction surgery. Dr. Vignesh, welcome to the MDT today.
Thank you for inviting me. Hello, everyone.
Great. Okay, so we'll kick it off today. The first, we are going to present three cases today, and we're going to have a panelist discussion on it. The first patient we'll present today is on breast cancer. The second one on a sarcoma patient, and the third one on a patient with a papillary thyroid CA. So the first patient, who is a breast cancer patient, is a 59-year-old lady. She's Chinese, she's single, and she works as an accountant. She's a never smoker and never consumed alcohol, and she's postmenopausal. Her past medical history, she's got a background of hypertension and some rheumatoid arthritis in remission. So she first presented in November 2020 with a very large mass over her left breast, which has gradually been increasing in size over the past 2 years. The growth is now ulcerating and it's bleeding on occasions. So when she presented at hospital, the surgeons over there performed a biopsy and it diagnosed her to have a G2 mucinous carcinoma, which was ER positive and PR and HER negative. The scans revealed there's no signs of systemic metastasis when they staged her. There's no regional involvement on her scans. And so she was diagnosed with a stage 3B mucinous carcinoma. So before we get into that, let me just show you the scan of what was presented. And you can see here, there's a very, very large mass over the left chest. And it seemed to be involving or in very close proximity with the second, third, fourth, and fifth ribs. And then it goes away. Sorry, move along. So, Dr. Angela, let's kick it off. If a patient comes in with a very, very large tumor over here and the biopsy has been proven as a mucinous, how do we go about this from an oncology perspective?
Yeah, so I mean, usually for such cases, we would definitely, of course, discuss it at our tumor board where, of course, everyone will be there, including the surgeons, myself, other radiation oncologists. So for T4 tumors, the challenge usually is how far, how deep, and how big the tumor is, and how morbid the resection would be. So in the indication for us to consider upfront chemotherapy would definitely be there. With the intent of giving neoadjuvant chemotherapy would be number one, to downsize the tumor and then hope that we'll be able to get R0 clear margins. And number two, chemotherapy would also be able to allow us to assess whether this, if the patient complete response from the chemotherapy, that actually portends a very good prognosis for this patient. So definitely for some, would consider giving neoadjuvant chemotherapy.
Great. Okay. Anybody's would say upfront resection for such a large big tumor? I guess we're not breast surgeons here, but I guess the verdict. I think we took a vote earlier, and yeah, so we will give her neoadjuvant, and that's exactly what she got. Sorry, let me just put it in and pause this. So she actually had 4 cycles of doxorubicin and cyclophosphamide, and 12 cycles of weekly paclitaxel. And so a repeat scan was done for her after she completed the chemo, and you can see the tumor actually really has shrunk down tremendously in size. but they really couldn't give us a margin whether the second, third, and fourth ribs were actually involved in this patient, and it was actually very close to the sternum too. So Dr. Padunket, after the chemo has been done, the breast surgeon, says that he wants to go ahead and sorry, I forgot to bring this up. So this is the patient at the end of the chemotherapy. You can see the tumor has shrunk quite significantly, and so right now the breast surgeon wants to go ahead and do a mastectomy and axillary clearance. He's come to you right now for a role. Is there a role for chest wall resection too?
So I think when we plan for the resection, we need to go back to the initial scan, because that's where we determine how much the invasion of the tumor into the surrounding tissue is. So for the initial scan, it's you can see it goes very close to the I think second, third, and fourth ribs, right? But not into the sternum itself. So when we plan for do the chest wall resection, to either to do the stenectomy or not to do a stenectomy is very important. Okay.
Yeah, so I think this is the part over here, the lateral part of the sternum over here. It's in very close proximity over here.
Right. So I think at least we need to do a partial stenectomy, but I don't think we need to do a full stenectomy because it's not a sternal tumor. So if you want, I think we should stay on the safe side because we're going to do a big resection that can cause a patient morbidity. So we need to make sure that we get them all. Okay. So what I would do, I would do a partial stenectomy along with the involved ribs to make sure that we got medial and lateral margin clear. And then we can reconstruct the chest wall using, if for the stenectomy, I would just put a plate inside the matrix rib inside and ask the plastic surgeon for the soft tissue coverage.
Great. So now I think one question we always ask ourselves is that though sometimes from the scan we can't see or can't visualize the actual margin, would it be safe to just do a full stenectomy along the length, like say if the second, third, and fourth rib are involved, you do a partial manubriectomy and then you continue to resect further down up to the fourth intercostal space and take out the whole sternum just to be on the safe side? Would that be advisable?
I think that can be another option too. But again, I think we can go back to the initial scan. If there's any bone cortex involvement of the sternum, I would do a full stenectomy. Okay. But from the scan that I saw, I didn't see any involvement of the sternal cortex. Just at most the soft tissue of the intercostal space that's involved.
Great. And would you apply the rules of chest wall resection to this, in the sense that we know this is a malignant tumor? For the ribs, do you want to have a margin of 4 to 5 centimeters away, or would it be a bit different for you when it comes to breast cancer?
I think it's a little bit different first, because that the chest wall tumor normally it's a sarcoma or soft tissue tumor. It does not have the chemo or radio sensitive like the breast cancer. You can see from post neoadjuvant, we don't really see any tumor left at all. So I think the idea of thinking the resection is different from the bone tumor itself.
Yeah, great. So I guess we want to keep that involved, that if you have a tumor that's actually very chemosensitive, you don't need to actually apply the 4 to 5 centimeter rule and the 1 rib above, 1 rib below concept, right?
All right.
So coming back, okay, so we understand the resection margins for breast cancer. We can actually reduce it as long as we get a good clear margin. What about the reconstruction part? Now, how do you decide bone cement versus plates nowadays? Or some people just put a soft tissue, just put a mesh and put some and put the muscle flaps over it. What do you think here?
I think it depends on how many ribs that you remove. If you remove 1 or 2 ribs, you don't really need to reconstruct at all, especially in the posterior part. But for the anterior part, that the soft tissue, it's small, and you may need to put in a flap inside, right? And if you still have the ribs margin left, putting the anatomical plate is always advisable for me, because the bone sandwich it's a rigid plate. It's constrict patient chest wall a lot. So if possible, and if you have a area to put on the plate, I would put on the plate first.
Great. Okay, so thanks, Dr. Padunket. Sorry, let me silence this. Thanks, Dr. Padunket. Can I, Dr. Vignesh? So right now, I want to talk about reconstruction with the flaps right now for soft tissue coverage. I guess as a plastic surgeon, you're always very concerned about the blood flow to the flaps. Can you run us through your thought process when we're discussing this MDT, and what you're concerned about the chest wall resection part?
All right, so this is a great question. So first of all, the primary goal is a chest wall reconstruction, which is very different from breast reconstruction in itself, right? So in breast reconstruction, you want to make an aesthetic looking breast. But here, what we want to achieve is to fill up dead space, cover your implants, cover your lung cavities that's exposed, or your permacore, and also have a durable coverage over everything else, right? So in that case, I would have at least 2 options here, well, possibly 3 as well. But first and foremost, I would like to know whether our vasculatures are maintained, right? So the first one would be internal mammary arteries, which supply our rectus abdominis as it goes into its terminal branches as the superior epigastric. So we are going to do a stenectomy, and definitely this tumor is on the left side. So the left IMA is gone, so which means the left superior epigastric artery will be not perfused as well. All right. So that's why we had this very long discussion pre-op as well as the start of the op, whether we're going to do a partial stenectomy or whether we're going to do a full stenectomy. And in doing a full stenectomy, there's always a risk that the contralateral, the right IMA may be traumatized. It may not have been cut, but it could be traumatized, and that could compromise our flap perfusion. So the first flap I would consider would be one from the tummy, which is the transverse rectus abdominis myocutaneous flap, where it's based on the rectus abdominis muscle and the lower elliptical skin just below the umbilicus. And for that to be viable, we need at least the right IMA to be patent, and which is what we did in this case successfully. But in that, taking that into consideration, once you do a lower abdominal flap, you need to close the lower abdominal skin. And when you do that, you actually stretch out the chest skin, and which is exactly what happened in this patient, whereby the defect, although when you look at it, even with the margins, it could be an X amount, but eventually once we close the abdominal skin, the defect actually enlarged quite a bit. So therefore, you need the entire elliptical abdominal skin. And basing that on a single pedicle is usually insufficient. There will be flap compromise, edges, partial necrosis, and so on. And that is why in this case, I took a DF perforator on the left side as well, and I joined it up to the IMA stump on the left side. So that's why the entire flap is viable, and we use the entire flap to cover the implants as well. So that's my first option. In another patient, for example, who had abdominal surgery before and the rectus abdominis is not viable, or we need to do a total stenectomy and both IMAs are not viable, then the options would be a more simplistic approach whereby we just use muscle coverage. We use the right side pectoralis major muscle as well as the ipsilateral side latissimus dorsi, and that should be adequate muscle coverage, but it will require skin grafting on top of it.
Right.
Yeah,
So
so
you just place the muscle over it and put a skin graft over it.
correct, because there's insufficient skin on those two pedicles alone to cover this size of a defect.
Okay.
Yeah. So the third option, which we've done in another patient, actually not in this case, but that patient had large pedunculous breast, size D or larger, and actually we used the entire breast, and we basically kind of like opened it up and covered the entire chest wall with that one single breast itself. And so it's called a Cyclops flap, which was actually written up in 1997. Yeah, so that was, it's a bit morbid aesthetically, but it served the purpose. Patient healed well, and she's still doing well now.
Amazing job. So, we're coming to about 20 minutes of this talk. So I'll just get down to what we actually did. So we actually did a left radical mastectomy and a level 3 X-ray clearance. We did an en bloc resection of the left third to fifth rib and a partial stenectomy and reconstruction with permacol and matrix strip. And you did the deep inferior epigastric perforated flap together with the tram flap. And so I'll just show you the audience the photographs of what the tumor looked like, our resection point. The breast surgeon did he cut the margins out, and the thoracic surgeon eventually we resected the ribs along and did a partial stenectomy, preserving the IMA. And what we did was I like to place a permacol in the inner layer. We used to use normal synthetic mesh, like a a normal synthetic mesh. But the thing is, we noticed that if there's any issues, risk of infection is very, very high. But whereas with a permacol, it's a biological mesh, it really, really helps to reduce the risk of infection. And even if we need to go back in, we don't find much adhesions at all actually with this. And once we did that, we placed the matrix strip above it. And of course, Dr. Vidnesh placed the tram flap over there and had a good covering. And the patient had a very good outcome. This is our specimen that we can see. And this is the X-ray post-operatively for this patient. And she recovered pretty well and went home after a few days. So finally, the histology component. So it was a 40 mm in size. It was a mucinous carcinoma. The tumor margins were uninvolved by the cancer. We had good margins with all around the tumor. And basically, at the end of the day, we had a pathological complete response for this patient. So, Dr. Angela, your comments basically, I guess my questions are like, will she require adjuvant endocrine therapy with aromatase inhibitors? And is there a role for any adjuvant RT here?
Well, just probably like a bit of background. Mucinous breast carcinomas are usually a very good, it's associated with a very good prognosis. So to think of it, this tumor probably grew over quite a long period of time. It's a fairly indolent subtype. And the good thing for this lady is, even though it probably took a while for the tumor to grow to that size, but there was no nodal involvement up front. And she actually responded very well to neoadjuvant chemotherapy. We actually gave the whole range of adjuvant, we gave the whole regimen of chemotherapy up front. So she actually does not require any more adjuvant chemotherapy subsequently. But mucinous breast carcinomas are very strongly hormonal positive. That means she probably has more than 90% ER receptor expression. So adjuvant endocrine therapy with aromatase inhibitors will definitely be required for at least 5 years. And I mean, I do kind of have to throw the question back to the surgeons. I mean, would there be a consideration that if we were to give adjuvant RT, would that affect her flap and the viability of it subsequently? Because whether it's required or not is a bit controversial, because she has responded very well. Technically, margins are clear, so it may not be necessary. Some may argue that the tumor is quite big. Maybe we should give it. But in view of the fact that she's responded very well, maybe there's no real need. And because mucinous carcinomas respond very well to endocrine therapy. So, Hrish, maybe I can just put the question back to you. Would that affect your flap if we were to give adjuvant RT?
All right, that's a very good question. that we always worry about.
Yes.
Having said that, for this particular flap, so that's why I chose this instead of the double muscle flaps. So this one has two pedicles, one from the right IMA and the other one connected to the left IMA. So in that sense, I'm quite happy and I'm quite safe that this this flap itself is quite robust.
Okay.
So if one, even if there's RT changes to one of the vessels, I'm quite sure it should survive quite well. So
okay.
that's the consideration. But the second consideration,
yes.
sorry, you're saying something?
Sorry, no, I said that's good to hear.
Yeah. So the second consideration actually is with regards to the rib implants, the matrix rib, and in that point, having a tram flap which is much thicker is actually a better option, because it actually, even if it thins out a little bit or it undergoes some fat necrosis, you still have some good quality, good thickness coverage of the implants, as opposed to, which we have seen in the past in a case where we do muscle flaps, and as you know, the latissimus dorsi, although it's wide, but it's actually very thin. So there is a chance that, and you're grafting over it. So if you do radiation therapy, there is a chance of desquamation of the skin graft, as well as thinning of the muscle, which may lead to implant exposure.
Okay.
So those are the considerations. Yeah. Thank you.
Okay. That's great. So I think this was put across to the patient. I think she opted not for adjuvant radiation, and with the intent or the thought process that cancer actually carries a very good prognosis. A 5-year overall survival of about 90%, and even up to 10 years, the overall survival is still about 90%. So she was quite happy to just go with adjuvant endocrine therapy with aromatase inhibitors for 5 years. So that's quite well tolerated, and she would rather go without RT and just close surveillance beyond that. So for breast cancer, usually for the first 3 years, we would usually see them at least once every 6 months. Subsequent 4th to 5th year, maybe a year, and beyond the 5th year, it's just once a year follow-up. And surveillance follow-up usually just requires a mammogram for the contralateral breast, and that usually would suffice. That's as part of the main surveillance guidelines for breast cancer.
Right, because being a thoracic surgeon and dealing with lung cancers, we do CT scans regularly for once a year. So, we always had that concern that CT scan them, so I guess that's not required for this group of patients then.
One thing I want to point out, Dr. Hrish, is can you go back to your chest X-ray post surgery, please?
Sure. Hold on a second.
And where you did put a matrix rib screw, it is very optimal there. I think I totally agree with you that you go deep into the right rib, not the costal cartilage. You can see he skipped the first 2 holes of the costal cartilage and actually put a screw in the bone area, which is had we have a lot of study into the reconstruction.
Yeah, I think a very important comment, because screws tend to get loose in the costal cartilage and it always dislodges. So Jenny, we always avoid, and we had Dr. Vignesh there also with us, who is an expert with molding plates. He does it a lot better. The plastic surgeons do it sometimes a lot better than us thoracic surgeons. So it was an honor to have you there to help us mold it properly.
It was fun, man. We gotta be nice too.
Yeah. So great. Thank you, everybody. So let's go to the next case then. I guess we'll keep the questions till the end, and then we can answer them from there. So the next patient is actually patient number 2, who's diagnosed to have sarcoma. So he's a young man, 36 years old. He's a smoker and a social drinker. He works as a supervisor. He's got a strong family history of cancer. His paternal grandfather had throat cancer in his 70s. His paternal auntie had breast cancer in her 50s. And he's a very large guy, and he was diagnosed with essential hypertension at the age of 18. So he presented actually with a pain and swelling over his back for 3 months duration. And so we performed the CT scan for him, and it showed a very large posterior chest tumor. Sorry, the screen's okay. And located at the level of the 7th to the 9th rib. It was iso-intense to the muscle and hyper-intense on T2. So this is the MRI part, sorry. and had a more central non-enhancing component that represented necrosis. The lesion seemed to involve the pleura and the right erector spinal muscle. So the MRI showed basically 7th, 8th rib showed loss of normal F1 fat signal. There was edema around there. The neurovascular bundle in the right 7th and 8th and 9th intercostal space are involved by the mass. The mass abuts the T7 to T8 neural foramen, but no clear intraspinal extension was demonstrated. The cord returns with a normal signal. And so basically we had this mass over here, a large mass at the posterior ribs from 7th to 9th rib, and it was involving the transverse process over here. So Dr. Padun can take it to you from here. Patients in our clinic right now. I'm sure we all want to get a biopsy first before we make a decision on what this is. Can I ask you, would you actually rather do a core biopsy, or would you do an open biopsy for this patient? What are your thoughts and what are your views on it?
I think we can start with the core needle biopsy first, and then see what the result is. But I think what's more important is that I think we know it is a sarcoma some sort, and it's likely to be a bone sarcoma or soft tissue sarcoma. The next plan is that it's about a resection. From the MRI, I think it is very likely that the nerve root is involved. So I think you need to call your spine surgeon friend to see what needs to be done more besides the chest wall resection.
Great. So we actually went ahead and got an ultrasound guided biopsy for the patient. And this is the report. It said a malignant poorly differentiated tumor with round cell and epithelioid features favoring sarcoma. So Dr. Angela Pang is our chief sarcoma oncologist actually in NUH. And Dr. Angela, what are your thoughts about this histology report or biopsy report?
Well, I'm just kind of glad that at least it says that it's probably a cancer. So at least, it kind of allows us a bit of a discussion down the lines of what to do if this were to be a sarcoma, whether it's soft tissue or bone. Very often, sometimes because of the location of the tumor, sampling may be a bit selective, and there may be a sampling bias. So based on this report, at best, we can call it a sarcoma, but without knowing what exactly is a subtype, as Dr. Penangkit mentioned kind of earlier that a lot of sarcomas are not necessarily chemosensitive. So based on this, we would really be hard pressed to offer anything in the neoadjuvant setting, because the concern we have is definitely when we give neoadjuvant treatment with chemotherapy or radiation, the concern is while we are giving neoadjuvant, would the cancer progress? If the response rates are not going to be great, you may actually lose the opportunity to be able to excise the tumor in complete with clear margins. So that's the concern that we have. And with this biopsy report, at most we can call it a sarcoma, but to offer neoadjuvant, we would really be very hard pressed, and we will be worried that it may progress while we give neoadjuvant. So we kind of had a discussion about it. So it probably would have to go back to the surgeons to be able to clear out the tumor, because the gold standard for treatment for all sarcomas is still going to be surgery.
Right. Okay.
Yeah.
Yeah. So I guess what we did was we did exactly that. We got the spine surgeons involved, and we went ahead and we did a resection of the posterior chest wall sarcoma. We started with a right paravertebral incision. The spine surgeon started the surgery. He did a right T6 to T8 nerve root ligation, a right T6 to T9 transverse process resection, the right and then T6 to T9 rib neck resection, and a right T6 to T9 rib head disarticulation. So what he actually did for us is that he took the tumor right off the spine, and he helped to disarticulate the costovertebral costovertebral junction, yeah. And so then we then proceeded to do a posterior thoracotomy, and we took the whole tumor out by resecting the 6th to 9th rib posteriorly. And now the issue, the debate was over here. So this is the surgery that was done. A patient is lying prone. You can see the spine surgeons isolated all the nerve roots. He managed to resect it. And we did an intra-op frozen section to make sure we had margins and the margins were clear. And this is the final outlook of it. The spine is over here, you can see. And then we resected the ribs. So the issue we found was, we love to use the matrix rib set, but there was nowhere to implant the matrix rib per se. And so we decided to go with a traditional bone cement, and we sandwiched it in the Prolene mesh. And so, Dr. Vignesh, can I ask you about flap coverage here for this component over here? What do you think?
Well, as you all have very well done in this case, you preserve the trapezius muscle, the distal end of it, as well as the latissimus dorsi, you can see at the top end of the picture. So actually those two muscles may be sufficient to be able to spread it out and to cover the entire mesh itself. So that's one. Two, if you require, depends on whether you require skin coverage. From this photo and from the original one, I think skin coverage was not an issue. So you just required some durable tissue over the mesh itself directly under the skin. The second option I would have if the trapezius was not viable or it needed to be cut as well as if the latissimus dorsi was involved, then I would consider doing either a turnover latissimus dorsi, which may not have been adequate to reach the lateral end, or we just do a free flap coverage using the latissimus dorsi as a free tissue transfer and just directly transplant it over this area and join up the vessels to the ipsilateral thoracodorsal vessels. So those would be my two options.
So silly question, I think, but sometimes silly questions need
no silly questions.
Is it possible to do a free tramp or something like that?
Yes, of course. So well, as recon surgeons, what we try to do is we try to minimize things that can mobilize the patient during intra-op, things that may go wrong. So if you're just looking at one part, one positioning, those will be my first two options. And of course, if those two are not viable, then you will need to consider turning the patient and either taking a free tissue transfer from the thigh, which also doesn't mean you need to turn the patient a lot, or then you have to do it from the front, like what you suggested, a free tramp or a free flap. Great.
Okay. Dr. Badunket, any other suggestions to get some rigidity in the posterior wall? Do you think we could have used plates for this patient, or what are your other options, or what could else be done?
I think you mentioned about there's no place to put in the proximal plate, so I don't think that should be done because at least 3 screws had to be put in, sometimes 2. But if the plate is dislodged, or the screw is dislodged, I don't think that's a good idea, especially in the back area. So I agree with you that you used bone cement sandwich like this. But normally when I do the bone cement sandwich, what I concern the most is that the area of the defect. We don't really need to cover the whole area. You just need to make sure that after surgery there will be no lung herniation. Because posterior part, there are a lot of muscle, and normally the rigidity is pretty okay already. So that is my concern when I need to do bone cement sandwich.
Would you not use the cement and maybe just put a mesh? Would that be reasonable? Because we all know that mesh eventually becomes rigid after some time, right? Once there's tissue in growth, but the earlier phase, it's not so good. But what do you think?
Well, in this case, that you resect the bone along with the overlying soft tissue, and you lost some soft tissue already, and you need to put some flap on, I would put a bone cement sandwich. But in contrast, if it's a bone tumor that you only remove the bone, sometimes the probably image is enough.
Okay, great.
I have a question. Could you bridge the matrix wave of matrix implants over across to the contralateral ribs?
I think it's very difficult because the spinous process is really in the way.
Right.
And you really have to mold it. And we don't know, because we know that the matrix rib is a good support, but whatever it is a lot of movement, posteriorly, especially with the spine. We don't know whether it's going to fracture or not. We don't know the impact of it, how you curve it around the spinous process. I think it's a very difficult task.
All right.
And it may not give you that right support, because I think it will fracture easily because the posterior part moves a lot. So.
Okay.
Any comments, Dr. Padunket? Okay, great.
Mm-hmm.
So that's what we did, and we got a good covering. Intra-op Frozen section was clear. So the resection margins were free. The closest margin was 1.2 centimeters away. And so it was a high-grade osteosarcoma, and the margins were negative. So Dr. Angela, you managed this patient post-operatively, and you gave him 6 cycles of cisplatin and doxorubicin. Now, my question is, how effective is actually this chemotherapy for sarcoma patients?
I think probably we will have to take this in the context of osteosarcomas. Not the most common in the chest wall region, but nevertheless, it does happen. If we were to extrapolate the data from children where osteosarcomas commonly happen, with surgery alone, the cure rates are only about 30% for patients with osteosarcomas. We have recognized from the 1970s that this is probably a tumor that has systemic metastasis, micrometastasis up front quite early, usually with mets to the lung. So with the addition of adjuvant chemotherapy, the cure rate for children is up to about 70% or higher for osteosarcomas. Granted, adults with osteosarcomas, usually the cure rates are slightly lower, but I would say adjuvant chemotherapy is definitely necessary in this case. And if we were to kind of in retrospect look back, if the initial histology had been consistent with osteosarcoma, sorry, but we would have been able to maybe make your life a little bit easier by giving some new adjuvant chemotherapy. But unfortunately, with a very non-specific histo subtype, we were not really able to give that. But usually, osteosarcoma patients would require at least neoadjuvant or adjuvant chemotherapy with cisplatin and doxorubicin at least for 6 cycles. Okay, great. Yes. So minimum is 6 cycles. Sorry, max is 6 cycles. Maximum is 6 cycles because doxorubicin has a ceiling limit. If not beyond which the patient would run into problems with cardiotoxicity, which would not be great because a lot of the patients are very young. Like for this gentleman is only in his 30s. Mm-hmm. Yeah, so maximum 6. Okay, great. So unfortunately, he went home pretty well. He comes back during his chemotherapy and says, he's got severe backache, and he felt the protrusion at the back. He felt it protruding more. So you can see here the CT scan. Basically, we found it very difficult to anchor this bone cement, and so we went overboard and we anchored it to the muscle over here, and it was extending, and eventually this is causing a lot of pain for him. So Dr. Padunket, if you see this scan, and would you intervene?
Right. If because it caused the patient severe pain, I would go in and resect it, refashion it. Mm-hmm.
Okay, great. So in the interest of time right now, so yes, we went ahead and we did refashion the thing, and really his pain really subsided tremendously after that. So I guess we have to be, or at least I have to be with my team, a bit more mindful on the extent. We're just worried about the anchoring of it, so we went overboard a little bit. But what we noticed is that there was a lot of reaction, a lot of fibrous reaction, that the plate was very stable. So we actually managed to cut the bone cement and take it out, and he recovered pretty well. So sorry, he had 6 cycles. So 4 years post scan, you can see now that he's very lucky man. He's there's no mets back again, and he's doing okay, but this gentleman, we do regular PET scans for him and we follow him up. Is there anything else we should do for osteosarcoma patient, Dr. Angela, on a follow-up?
Yeah, so osteosarcoma patients, unlike breast cancer patients, they have a very close follow-up regime, because usually if they were to metastasize, we would project that the first 3 years will be at the highest risk of like systemic metastasis. Beyond 5 years, they will be pretty much in the clear. So I think this gentleman is doing really quite well. This is his 4th year scan. For the first 3 years, we would actually scan him periodically, about at least once every 6 months, with systemic scans, not just a PET scan would probably replace our old-fashioned CT scan plus bone scan, but in the older setting, or if the patient is unable to afford it, we will usually do a CT scan and a bone scan every 6 monthly, at least for the first 3 years. And the 4th and 5th year will be once a year. And beyond that, he will be in the clear and probably wouldn't need any imaging unless clinically indicated.
So after the 5-year mark, you tend to discharge the patient, or would you still keep him on a surveillance?
Usually after 5 years, the standard recommendation is you can discharge the patient, but most of the time we will usually follow up just to be really sure for another 1 or 2 more years. They're really all in the clear, then we can discuss with them about discharging them to the community.
Great.
Yeah.
Dr. Padunket, in your center, is there a different follow-up protocol?
I think it's pretty much the same, that we do less PET-CT. We normally just do a CT scan and non-contrast, and every once in a while we might do PET-CT, normally mark at 2 years or mark at 5 years.
And after 5 years, do you give an open date, or they don't?
I will just do a CT scan annually.
Annually, and do you have an end of the year, end of time mark at 10 years? Would you?
Probably 10 years, yes.
Probably 10 years. Okay, great. Okay, cool. So in the interest of time, we'll keep moving on. Why I want to speed this up a little bit is 8:45. Our session's for 1 hour, but what we're going to do is we're going to have a quick discussion on one of our doctors from Malaysia wants to put up a case for us to discuss too, for everybody. So the third patient basically is a patient who had papillary thyroid carcinoma. He's a 56-year-old Chinese male. He's a never smoker. He's a social drinker, no previous medical illness. He presented basically with swelling over his Manubrium sternum for about 2 to 3 months duration, gradually increasing in size. So the CT thorax done basically showed an ill-defined irregular soft tissue mass in the superior mediastinum with destruction of the Manubrium. There were enlarged mediastinal nodes suspicious of nodal disease, and indeterminate borderline right supraclavicular node. There's no other suspicious lesions picked up anywhere else. And the PET scan basically said the same thing. It showed evidence of a hypermetabolic mediastinal and right supraclavicular and suprasternal adenopathy suspicious of nodal disease, but there's no disease anywhere else. So here's the CT scan, and I'll just run through it very quickly. You can see there's a large tumor coming up over here. This is involving the clavicular Manubrium joint, and also the Manubrium is completely involved and encased in the tumor, and the rest of it looked fine. This is the sagittal view of it. And so this is the area of concern. We felt there might have been involvement with the trachea also. Okay, and the sternoclavicular joint was involved. So I go straight up, we perform a biopsy for the patient, and it turned out to be a papillary thyroid cancer. And so I want to get into the discussion with a tumor involving the Manubrium and also the sternoclavicular joints. Dr. Padunket, the first thing we're concerned about here basically is people are always concerned about resection of the clavicle and Manubrium and thinking that the patient is going to lose their arm mobility. And we talk about reconstruction on that component. What do you think of it?
I think it is very important to take the shoulder stability into the consideration. So for this patient, if we need to do a resection, we need to do the upper stenectomy along with the bilateral sternoclavicular joint. When it comes to resect the sternoclavicular joint, I try my best to preserve one of the side of sternoclavicular joint. So at least we have a place where that we can put a plate on the clavicle that need to be removed out back to the sternum. But in this case, I don't think, it doesn't seem it can be done like that. We need to remove whole of them and probably cut the clavicle 1/3 or 1/2 out along with the specimen. So we need to think about because if we don't do anything at all, we need to do the bone reconstruction. The patient will lose the ability to move arm back over the shoulder like this. So I think we for the bilateral sternoclavicular joint resection, we need to find the chest wall, the rigidity that can fix the clavicle back to the center. Mm-hmm.
So we didn't have that option here because we actually had to resect the manubrium and everything. The manubrium, the first, second ribs, and bilateral, the clavicles, partially at least, to get the margins clear. And so once that is done, do you think there's a role to plate it or just put a bone cement over that area? What do you feel, or do you have any other options available?
I would put the plate across the clavicle and anchor with the bone cement after the stenectomy reconstruction.
Right. So I mean, there's no what's the right wrong answer. I just want to tell you my experience of doing that. What happened was we found that the patient actually became more rigid with that, and he had a lot of pain on movement because it kind of fixed the clavicle. So the clavicle really wasn't mobile at all.
Right. That's a problem too. When we need to do this, we need to really discuss with the orthopedic surgeon, the clavicular surgeon, see what the best options are. I used to thought about putting the bone cement and put a plate over the clavicle and on the bone cement. It doesn't fix well at all. We tried it once. The screw came loose. No, there's no point doing that. Mm.
Okay. So about what we did on our side, but Dr. Vignesh, so we're going to resect all of this. Of course, we need coverage, and I guess high up in the chest, what do you suggest we cover it with?
Yeah, so again, it depends whether the skin is required or not. In this case, I think the skin could have been spared. The tumor doesn't look like it's involving the skin. Mm-hmm. So if the skin is spared, then you just require a durable coverage over your reconstruction or over the great vessels that it's going to be exposed. So in this case, the simplest thing would do, if you can preserve the bilateral pectoralis major, that's what I would use. And my backup would be if the thyrocervical arteries, trunk is patent, not violated during the surgical resection, then we could also consider a supraclavicular flap, which is a skin flap based over just above the clavicle area, and we can turn that in and de-epithelize it to give it a good thickness coverage as well. So those two will be pedicle options. Of course, the third option would be a free tissue transfer either from the abdomen, like the DF flap, or latissimus dorsi from the back.
Great. So I think that's what he had basically. We did an en bloc. So this just to cut the time short, basically this is a papillary thyroid CA, and we knew it was metastatic to the lymph nodes. I know, Dr. Angela, you don't deal with papillary thyroid because it comes under the endocrine doctors, but before we go into the resection, what do you do? Is there any role do you feel for any neoadjuvant here?
Unfortunately, for papillary thyroid cancers, typically they're not chemosensitive, so that's for starters. And we would usually save systemic therapy really in the instance where the disease is metastatic, and we have ran out of other local ablative options, because usually we consider papillary thyroid cancer as a type of differentiated thyroid cancers, which means they usually tend to be fairly indolent and such. So treatment options usually would be very much surgery if it's feasible, and if the tumor is amenable to surgical resection. Number two would be radioactive iodine. But radioactive iodine, we know it takes some time for it to work. So upfront, to be honest, for papillary thyroid cancers, we don't really have anything upfront in the neoadjuvant setting to be able to downsize your tumor, if that is the question that is posed. Most of the systemic treatment options are pretty much in the refractory setting. I'll kind of put it that way.
Okay, great. So, we discussed him in the tumor board, and we did opt for upfront surgery for him. So he had an en bloc resection of the superior mediastinal lesion, along with the manubrium and sternum, and bilateral, the upper sternum, and bilateral partial clavicles, first and second rib, total thyroidectomy. The tumor was stuck to the trachea, so we did a tracheal resection for him, and anastomosis. We reconstructed the chest wall with a titanium mesh. So I decided to not use the plates anymore because I felt that it was really impeding patient's movement. So we used the permacol as the inner layer and a titanium mesh above it. And that actually gave a good support to the patient. And of course, the plastic surgeons helped us with the myocutaneous flap and right pectoralis major muscle flap. So this was the surgery performed. Yes, we managed to preserve the skin over it. Over here, we cut the ribs. And then we use a jiggly saw to cut the clavicle. And then we disconnected the sternum from the bottom here. And this is our anatomical view. The tumor was stuck to the anterior part of the trachea, so we did a tracheal resection for him. And this is the permacol that we placed above it for coverage in the titanium mesh, which we anchored to the clavicles. So I drilled holes into the clavicles bilaterally and used Ethibond sutures to hold it into place, and we anchor it all around. And this is what it looked like. And then we used the muscle flaps to cover the defect. So it turned out to be a papillary carcinoma, 1.2 centimeter in the right lobe. Left lobe had no tumor. The level 7 and 8 nodes, mediastinal nodes, and lateral leg nodes were all removed. And but however, we did see microscopic tumor margins were positive at the tracheal border. So what unfortunately for this patient is that on post-op day 7, he started getting a lot of voice changing, difficulty to breathe, and the flap was getting blown up in front. We did a CT scan for him, and we found out that he had a tracheal dehiscence. And so we went back in. One thing I wanted to say is that by using the permacol, we noticed that really the area was very clean. There wasn't much adhesions at all from the area, and so we could actually access that defect very easily. And what we do is we mobilize the pectoralis major muscle, and we use it to cover up the hole over here. And surprisingly, he got discharged a few days later after that. This is the bronchoscopic view of the flap covering from inside the trachea over here. So this is what he looks like right now. And surprisingly, yes, he's unable to lift his hand forward quite a bit. But other than that, he's got good mobility. He can feed himself. He can shower himself. He's doing quite well. Now, the follow-up scan at 3 months was quite good. It was quite clear. And it looked well. Now, the issue is that what I want to bring up here is that the pre-RAI, so he was given radioactive iodine, and his TG was 128 before. However, after the radioiodine was given, we did a repeat scan for him. It didn't show any radioiodine uptake to suggest any distant metastasis or regional lymph node involvement. However, he presented just recently with a swelling over his chest, post-op 6 months right now. And the first thing I want to move up, is that he's got an enlarged supraclavicular lymph node now that's actually getting bigger. And unfortunately, there is a new lesion in the distal part of the sternum over here. So these are the two areas of concern right now. Now, we've already given him radioactive iodine. Dr. Angela, what next? I mean, we know it's a metastatic disease. What next for this patient? What do you feel?
Most of the time, if the radioactive iodine has been given once up front and they are in the clear, most of the time we would probably repeat an uptake scan again.
Mhm.
If indeed the sites of metastasis show that there is uptake, then there's actually a role to repeat radioactive iodine. It's not a one-time off thing, so they can actually repeat the treatment again, and with an interval imaging to see how good the response is. And then if let's say it's really not responding after at least another one more trial, and if the disease is moving very rapidly, if the patient is symptomatic and if the tumors are not resectable, if they are isolated to separate sites, there may be a role for ablative radiation to those areas. So as I mentioned, systemic treatment, we have options, but we will leave it a bit further down the road. Most of the time, at the time they recur in this setting, we would already send the tumor for what we call molecular analysis. So for papillary thyroid cancers, the targeted therapies we use is very much based on the molecular expression, if any, whether they have any molecular driver mutation tested on molecular testing. The common ones would be ALK and TRAC, as well as MET molecular mutation. Let's say they have any of these tested positive, they're actually specific tyrosine kinase inhibitors that can target these molecular targets. If they are all negative, we would usually use what we call VEGF inhibitors, multi-targeted VEGF inhibitors called lenvatinib or sorafenib as targeted all kind of tyrosine kinase inhibitors.
Okay.
Yeah.
So, I mean, right now, when we did the repeat scan after the radioiodine, it was clear. He didn't have anything. But 3 months later, now he's got this big tumor in the chest right now that's growing fast. And there's a large supraclavicular node now over there. Now, do you think we should do upfront surgery, resect it out, and move from there, and then after that repeat the radioiodine? Because these are bulky tumors, it's growing fast, and you know.
I guess if the patient is very symptomatic, the argument is yes, you can probably consider doing surgery, but then of course the thought process would then be if the second surgery is going to be very morbid and the interval between the progression is quite short, then we would really have to send it out and present the picture to the patient that we may not be able to clear everything, but if they're very symptomatic and they would need the tumor to be excised out for palliation of the symptoms or whatnot, then there's always an argument that yes, probably surgery can be considered, because the other options are also not entirely fantastic in a tumor that is growing otherwise so fast.
Great. Dr. Padunket, what do you think? What are your views from the surgical resection point? Should we
I agree with Dr. Angela, because the disease-free interval is just too low, too small. And it's not only the sternum, you also have the left supraclavicular lymph node. If you do PET-CT, there might be more metastasis outside. So unless the patient is very symptomatic, I wouldn't do surgery.
Okay. Dr. Vignesh, one question. Say the team says, okay, the tumor board decides, okay, look, go in and resect whatever is growing rapidly. We're literally doing debulking surgery here, which is probably not a good option for this patient. But say if we do resect the sternal mass, and I think we still manage to have skin covering, are there any options for any muscle flaps, or you think just
Yeah, we definitely can pull over pedicle bilateral latissimus dorsi or unilateral latissimus dorsi. It's still possible. And the other option otherwise is just to do a rotation flap from the upper abdomen and swing it up just to cover that area, and you can de-epithelize it to bury it under the skin as well to give it a bit more bulk. So those two are possible options for this kind of not really curative kind of surgeries that you want to at least temporize and allow the wound to heal.
Right. What about the previous pectoralis major muscle that was used? Can you use the left side is patched over the trachea?
Exactly.
Can you mobilize the right side down and bring it down?
So you could, but then the question would be, you opted to use a titanium mesh.
Yeah.
So titanium mesh in that gentleman's skin, as you see his live photo, his skin is quite thin already. So to try to go in a scarred area, number one. Number two, to try and separate out the muscle from the skin and then from the titanium mesh will actually cause the muscle to be either come out in tatters or, it's going to be very thinned out.
Okay.
And then you compromise your titanium closure area on the second hand as well. So I would not consider that.
Okay, great. Well, thank you very much, everybody, for this discussion. We're kind of at 9 o'clock right now. Dr. Sun gave me a call just now and said, in Malaysia, in Sarawak, they have a very difficult case. So this is putting us on an impromptu. Is our Malaysian colleagues here with us?
Yeah. Hi, am I audible?
Yes. Hi, Parvin. How are you?
Mr. Hrish, I'm okay, fine. Right. I'll just go straight to the case because we are a bit late, I guess. You could see my slides?
Yes, we can.
All right. Okay. So I'll just proceed. So I'm actually Dr. Parvin here. This last minute case for a discussion from all our panelists and our audience. I'm actually from Kota Kinabalu Subacqueen Elizabeth II Hospital, Department of Cardiothoracic Surgery. So I have a patient here. We have a patient here, Miss J, 36 years old female, who is married with 4 kids, non-smoker, housewife, pretty about fair size, 32 BMI, ECOG is 1, ADL is independent. She actually will go through the brief history. In 2008, up to 2010, she was well. 2010, she developed chest pain, actually penetrating in nature, anterior to the posterior with the constitutional symptoms. So the normal line of investigation was done for her, whereby an X-ray followed by showed the widened mediastinum, then a CVCT was done, showed a posterior mediastinal mass, then an HP showed by CT guided is a giant cell tumor. So the patient subsequently underwent an excisional biopsy in 2010 itself, about 11 years ago at another tertiary hospital. But unfortunately, we don't have the details of this, what exactly happened and what was done here, because it's about 11 years, and patient don't have a copy of that report. Now, up to 2016, she was well. Now, in 2016, she presented again with similar complaints. And this time around, the case was under the orthopedics team. Then they did a transpedicular biopsy, which also again showed a giant cell tumor of the bone. And she was put on 6 monthly MRI surveillance. Patient is also she's in view of the far distance and so on. She defaulted 3 follow-ups and MRI follow-ups. They managed to get hold of her on August 2020. That is about 4 years later. And an MRI thoracic was done at the point of time. So this is the finding. So they noted there is a T4, T5 vertebral body mass with a pre and paravertebral extension. This is the size 6 times 8 times 8.7. And the lesion is also extending anteriorly into the posterior mediastinum, partially encasing the posterior part of the trachea, cranial junction, and completely encases the right main bronchus. But the main bronchus is patent, okay, as well as the ribs. We are also, in view of that involvement of this, they did a CVCT thorax, which shows similar mass size. Okay, this is the finding. The superior extension is until T1 and inferior is until T7 vertebral body, right? And it also causes mass effect to the distal trachea, bilateral main bronchus, intermediate bronchus, and right upper loop bronchus. And they also have seen fibrotic changes in the apical and posterior segment. Okay, and the mass is seen in close proximity of the SVC, left pulmonary artery, bilateral superior pulmonary vein, and posterior wall of the left atrium. But all these vessels are patent. Right? This is the latest MRI thoracic they have done. It noted that the mass is increasing in size from 8 times 9 times 8.9. It has gone up to 9 times 11 times 9. And now it has fully engaged the proximal right bronchus and now it is causing some bronchial luminal narrowing, most likely compressed from the mass, right? Now, these are lung function tests, quite fair. All the blood investigations are normal, the clinical functions are normal, no neurological deficit, is in ECOG 1 status, NYHA class 1. So this case was referred to us in the September 2020, end of last year, for opinion of in view of the intrathoracic extension and in view of the recurrent giant cell tumor involving the right hemithorax. And this case was initially discussed with Mr. Soon and another spinal surgeon from Kuching. Planned for resection and reconstruction, and unfortunately, all of us knew that COVID was at a high level at that time, so it has been postponed. So we just got another re-referred this patient back. So the orthopedic in-house team is planning to do this instrumentation of stabilizing the T1 to T8 with the transpedicular debulking of T4 and T5. So we will see the scans. Okay, this is the CT thorax done, CT thorax done in August last year, 2020, right? Just scroll.
Can you scroll up a little bit to the level of the pulmonary artery over there? At the level of the carina? Yep, slow down a little bit. Yep. Yep, keep going down. Right. Oh.
Show the MRI, the latest MRI with. Okay. Yeah, this is a surgical view.
Yeah, you know, just as you scroll, I just want to have a discussion. The whole vertebral body is involved with this giant cell tumor. I know giant cell tumors are not malignant, it's benign, but it does grow and does erode. How are they going to preserve the cord function of this patient?
They have seen the patient actually recently because this patient was admitted for the MRI, but they have not explained that to the patient. They said they have consulted for the procedure, instrumentations, and they have quoted risk of paraplegia. So and this mass is reported as there is an extension of the mass into the intraspinal space.
Yeah.
Which actually obliterates both neural foramina.
Yeah. So,
I think a spinal surgeon is in the audience actually.
Oh, great! Would you like to bring him on board?
Mr. Fu, I think. Maybe Mr. Fu, you want to type your rationale in, or maybe we give him some time to type. I think the surgeon is in the audience. So
soon, from my my comment is that for the thoracic component is this tumor already impinging, or it shouldn't invade, right? It shouldn't invade the pulmonary artery. but I don't know whether it is actually going. Is there lymph nodes around there that it's causing that area to be very hazy? Whether the PA is involved?
Yeah, of course, that's going to be a factor to consider. But if my main consideration is that the spinal part, if the spinal surgeon is keen to go in and wanted to resect that, I think I'm just a little bit obliged to be able to provide some sort of support for him. I think teasing it off the trachea, teasing it off the pulmonary vasculature might involve some creative work or proximal control. But I think probably we should be able to do that. But the main concern is just the spine for me. But I'm no expert in spine, so yeah, I think Dr. Fu is in, so he has some comments. Maybe we can look at his comment. Yeah, he's from the QEH spine team from KK. So Dr. Fu, how were you going to manage the vertebral pathology?
I've got a comment from maybe Angela, you can help us to review this. I think Dr. Nara said that GCT may show good response to pezolfinib. Do you have an experience here with this?
Yep. I mean, the thing is, we've got usually we do have quite a lot of cases of giant cell tumor. So first and foremost, it has to be really confirmed that this is truly a giant cell tumor. I can see, based on like the imaging, it's a very calcified mass and everything, which looks very much like probably either a giant cell tumor or a malignancy that arises from the bone. So if it's giant cell tumor, yes, we do have systemic therapy options that can help control the disease. But first and foremost, my question is, if the spine is not stable, and if the patient is at risk of any local crisis and such, surgery would still kind of have to be the main crux to be able to stabilize the spine. We don't use a pazopanib or any tyrosine kinase inhibitors. We use the denosumab, which is a rank ligand inhibitor. It does have a bone modifying effects on the osteoclast and osteoblast. So basically, it can modify the bone and it can strengthen. And based on phase 2 studies, we have seen patients respond to the denosumab in the event where the giant cell tumor is recurrent, it cannot be resected and such. But in this case, I mean, my main question is, instead of thinking about the denosumab, which may actually make subsequent surgery a bit difficult, because we have had experiences with our surgeons with that, the question would then be posed back to the spine surgeon whether the spine can be stabilized in any way before we proceed with giving my systemic treatment for this.
But I think Dr. Fu replied and said we are planning to stabilize the spine from T7 first and then resect T4, T5, vertebral column and reconstruction of the anterior column.
Okay, cool. And he did also mention that the patient has been on denosumab for the past 18 months. Yeah. So this image is pre-denosumab or post?
This is probably post, isn't
it?
Post,
because it's quite recent.
Yeah.
Okay, fair enough. So I guess this is probably 18 months is sufficient time for whatever response it can give or offer to reduce the skeletal related event. But that's probably the maximum denosumab can achieve at the moment.
Great. Dr. Padunket, any comment? Dr. Soon, I think we need to really assess that pulmonary artery, and are you at risk of actually having a pneumonectomy along? I've never dealt with a giant cell in the thoracic cavity before, so I don't know whether it comes right off. Maybe we can ask some participants if they've had this experience before.
Yeah. You want to show the CT scan as you go along? The CT with contrast again.
I don't really have the giant cell tumor with the intrathoracic too, but from looking from the CT scan, I would really concern the right main bronchus trachea, because it's in the membranous portion, and with that tumor compressing to it, you have a high chance of comes out with a right pneumonectomy. So if there's any neoadjuvant, I would strongly recommended.
Dr. Panungkit, I think they did already give the denosumab in the event of like considering as neoadjuvant to kind of stabilize the bone. But this is already after about 18 months, which is about a year and a half of denosumab for the giant cell tumor already. Yeah, so I think that's probably the maximum effect that it can have on the bone.
Yeah, so the primary surgeon from KK is in, Dr. David Tang. So David, you have any comments on that?
Well, this case was just referred, I think, around 3-4 days ago. So I actually didn't have time to go through all the scans. And we just got the CD of the MRI today. So I thought maybe it would be a good time to discuss this based on the since you're having a chest wall tumor thing. I'm not sure whether it's resectable or not. A few things that cross my mind. Even if I can resect, I don't think I can resect everything. I was just thinking whether there's any other drug available which we can control it a bit better, and maybe neoadjuvant chemo or something like that, and then after that do the surgery. I mean, I don't think there's any thing for giant cell tumor because it's not exactly a full-blown malignant thing. So I'm not very sure. I think the mediastinal tumor cases with giant cell tumors, I think there are very rare cases of a number of cases like this lying around. So on top of that, this patient is highly non-compliant, and she has just gone home yesterday from the orthopedics ward, and her next appointment, she says she only wants to come back after 1 to 2 months. So I'm not sure. Mr. Fu is in the audience. He's the orthopedic surgeon. He referred the case because he wants to stabilize the spine. So in the long run, what are we talking about here? So I just wanted your opinions with regards to this scenario. Is that okay?
Mr. Fu is in as well as a panelist now. Mr. Fu, you have any comments on that?
Actually, for this patient, I think the spine side, she have no more any tenderness, and then it's quite stable in the sense of in terms of the neurology wise. Then, but my only concern is the approach, whether we should like do the posterior stabilization, then only follow by the cardiothoracic side to resect, or should you all resect first, then only we put up the implant. Yeah, because as I understand, if I put in the implant, my disturb means very difficult for the cardiothoracic team to like approach, open up the chest.
I think there was a plan 6 months ago, but then I think the tumor has grown much more now compared to
yes, definitely
6 months ago.
Definitely.
So I'm not sure whether it's resectable or not in the first place. So
okay.
I don't know.
Yes.
So I wanted the opinion of you guys. What do you all think? If you think that it's not worth doing, then we will not proceed anything further.
Do you have the latest scan? Because I haven't seen the latest scan. Is the latest scan out? Is the latest CT scan out? Just now it was
This is the latest
one that was last. Was it the one that was most recent, or it was the one last year?
This is the last year's scan, the CT scan, but we have an MRI latest.
Yeah, the last year's CT scan. You don't have a latest CT scan on this. Huh? No. So what do the rest think? According to the MRI scan and bearing in mind that the tumor has grown in size over the past 9 months, worthwhile?
I think the first question we got to ask ourselves is that you're going to do really extensive surgery where she may end up with a pneumonectomy, and are you going to get a complete clearance or not? So if you're going to have an R1 resection in these cases, and after a pneumonectomy for a patient, I feel that are we benefiting the patient with? Is there a risk of paraplegia for the patient too? I mean, eventually the spine's got to it will erode into the spinal cavity, isn't it?
Yeah. So.
And so is there a role just to stabilize the spine and go from there, or?
Yes. Actually, my initial plan, at least we will stabilize because I can see the kyphosis is getting worse. And then, yeah, we will try to clear the margin so that at least buy some time for before the cord totally get compressed by the tumor. At this moment of time, patient have no neurology deficit, still walking and without any back pain at all so far.
And if I can, Angela here, if I can kind of like, present the overall picture of giant cell tumors, most of the time, the patients do not metastasize. They do not die from giant cell tumor either. It's just a very locally aggressive intermediate kind of behavior tumor. So most of the time, the crises that we face are local. It's very much on the location of the tumor and such. Even getting R0 resection may not really be like the 100% necessary things. A lot of our surgeons actually, they curette out the tumor instead of excising it out and whole. I mean, this is what I have seen from practice. And most of the time, we kind of support with the denosumab either before surgery or after. But there is a limit to how much the denosumab can help with the bone stabilization and everything. But most of the time, the patients with the tumors in the spine, they inevitably will need some kind of spinal stabilization. Because even with the denosumab, you can see a lot of the tumor is kind of eaten up. So, the spine will kind of lose the stability, and either the patient becomes kyphotic or they get cord compression. So it's very much going to be in the surgeon's court at the moment. What is it that we can do to stabilize the spine? She probably wouldn't die from this. Yeah, so it's not something that the prognosis is dismal, but she is quite young. She's only 30 plus. So I guess planning of what we're going to do, how morbid it is, what are the eventual functional outcomes we can achieve for her would probably be the most important, I think.
Well,
yeah.
Well, what if you just to debulk the tumor as much as possible without doing a pneumonectomy? Because the pneumonectomy drops everything back down, and then he stabilizes the spine. Would there be any available drugs or anything like that, or radiotherapy, which might actually help?
Already had the denosumab.
Okay.
So denosumab is the drug that is given for this. She's had it for 18 months, which is about 1.5 years. It's quite sufficient and quite a lot already. Radiation, we would be quite hesitant to offer radiation because this is not a malignant tumor. And she's quite young. If we were to radiate now and she gets a sarcoma and later in life, it's very, very difficult to account or justify for. So usually we don't radiate giant cell tumors generally. So I guess that's probably like all I can offer from a medical oncologist point of view, but this is the general picture that we have for patients with giant cell tumors. It's quite common actually. Common enough for us to see quite a bit in our sarcoma team.
Well, I hope we could help in some way, Dr. David and Dr. Fu. Maybe we should take it to the patient and see what they want. But Dr. Sun, do you want to put it through you want to put a scope in and just take a look at the extent of the mediastinal invasion before you proceed with anything else? That may be an option for you.
What, Dr. Hrish, just what if such patient came to your clinic, what would you do? I'm just on your opinion.
I think firstly, we need to look at the latest CT scan. Previously, it looked quite invasive and it's gone quite deep into the chest already. The idea for me, at least, basically, is that if I do surgery and you want to debulk it, when I perform the surgery for her, will she inevitably need a pneumonectomy when we're doing the surgery for her? I think that's the most important thing for me, because with a pneumonectomy comes a lot of other things too. And stump blowout, risk of infection. You're putting in plates to stabilize the spine. Can that get infected? So all these things come into play. And is this patient even compliant with the treatment? Sounds like she's not. So I think I want to do the minimum for her with the maximum best outcome. So generally, I think I would really put a scope inside first to assess and see the extent of the invasion into the mediastinum. And then from there, make a decision whether we should proceed or not. But I think what's impending is the spinal cord. I think that's the worrying part for her. And so I would focus on stabilizing the spine, and then during that procedure, put a scope in and assess and see the extent. So we can even do, doesn't need to be in one sitting, it can even be in 2 sittings and decide then.
Okay.
Two more things. Need to make sure that the esophagus and the left atrium is okay too. It's all around that area.
Okay. Soon, what do you think, Soon?
David, I will be there to provide you with any moral support that you require. Yeah, but I think, you know, you've got to really have a word with the patient and see what sort of to what sort of degree would you be willing to undertake the risk. We can, you know, obviously leave behind some tumor along the bronchus, along the PA, along the carina area without sacrificing the lung. But, you know, what's the aim that we're trying to achieve? You got to discuss with her. The main thing, if the main thing is just to stabilize the spine, then I think maybe the spinal surgeons can do that. But if you want to go a little bit more and try to get some of the tumor out, probably we can, you know, preserve a right lung. We don't have to be so aggressive as to make sure that our margin is are not.
Okay, thank you.
Okay, great. Yeah, guys, we're about half an hour off our time, but can you give me maybe 5 or 10 minutes just to have a quick Q&A with the questions being put up? So the first one actually is from Dr. Ronald Winardi. He asks, how about cryo in sarcoma chest wall tumors? And anybody has any experience with cryotherapy?
No.
No, I don't have any experience in it. Dr. Angela?
Very limited experience, and I think most of the evidence for cryotherapy in chest wall tumors is very anecdotal. It's basically case series and case reports, not really standard of care unless there's any particular reasons. We have seen patients who have had cryotherapy done. If the tumor is actually quite small, and we are worried that radiation or surgery would actually affect the nerves. I have seen people use cryotherapy before. Not too bad, but long-term results, I'm really not sure, because a lot of them may have just had it done quite recently because it's a fairly new procedure. So maybe I think it will probably be better to see whether there's more data and evidence to support such treatment, because it's quite new in that sense. So yeah, that's probably all I can say.
Okay, great. Prof. Augustine had a comment. He said, for chest wall resection and spine resection, there is a special Medtronic spine hook with which you can anchor the rib matrix to the spine with this hook. So maybe we're just information for everybody, so you all can go to your vendors and ask them for it. Dr. Vignesh has answered a few questions that was put up already. So I guess maybe let me just scroll through it here. Yeah, so I guess that's about it. I think that's important. So, you know, thank you, Dr. Padunkit. Thank you, Dr. Angela. Thank you, Dr. Vignesh. You know, great welcoming Dr. Su, Dr. Fu, and Dr. David to the discussion. I wish you all the best with your patient. I hope we could shelter some light for your case. And, you know, thank you, everybody, and have a good night. Thank you for coming.
Thank you. Good night.
Thank you, everyone.
Thank you.
Bye.
Thank you.
Bye.